Welcome to Primary Care Conversations with Christine and Jeff, providing valuable and engaging pearls of wisdom on a broad range of topics relevant to your practice. Now join your hosts, Dr. Christine Palmay and Dr. Jeffrey Habert, as they guide you through the ever-evolving world of primary care.
Welcome, everyone. It has been a long time. Christine, nice to see you. It's been a few months.
So a little bird told me you just got back from Japan.
I did. It was great. It was really nice. Like quite a country. I mean, Tokyo is astonishing. Yeah, it was quite good. But a little sleepy because it's 13 hours ahead, but interesting. New backdrop, as you notice, different room. And I apologize for the Montreal Canadiens.
That's okay. You know, my sports knowledge ends with Go Blue Jays Glow. So we're good, but you did change the backdrop. And welcome back. I'm glad you had a good time in Japan. I just wish you brought better weather with you because apparently it is supposed to be spring, which is synonymous with the birds and the bees. Not quite happening, but even still, we are here with an esteemed guest speaker, Dr. Claire Jones, who's a reproductive endocrinology and infertility specialist, to talk about birds and bees and infertility.
And I want to add that Dr. Jones works at the Mount Sinai Fertility Group in Toronto. So right in our backyard for many of our listeners and certainly for us.
Welcome, welcome. We're so happy to have you here. And, I was just sort of thinking, and when we were brainstorming, infertility is probably one of the most Googleable conditions on the face of this earth. And you can have your patients jump into many rabbit holes. So I think the purpose of this podcast is, number one, to hear your expertise view for what you recommend, any new updates to guidelines, and as a primary care, predominantly readership, and certainly Jeff and I are primary care, what do we need to do? What shouldn't we do? And what should we just refer to you for your expert knowledge and assessment?
That's perfect. Thank you for asking that, Christine and Jeff, because we actually looked at some of the literature recently because fertility is this area that's been rapidly evolving. There's just more and more technology in this area all the time. You're right, the internet is full of all sorts of advice for patients and all sorts of, false hopes around take this supplement, try this out, put your legs in funny positions and try all sorts of strange things out there that's really not evidence-based. And that's really tough for patients to navigate and try and figure out what's really important, what really makes a difference. And until recently, there hadn't been any updated guidelines in a very, very long time. But recently, the World Health Organization just put out a guideline on infertility in general. And so there is some new guidance out there in general that I think is very helpful for family physicians. You can sort of easily Google the World Health Organization guideline to kind of look at what's out there right now. And they have some beautiful little infographics about how to sort of take a patient in your office and think about what tests are sort of going to be important tests to do and what sort of questions you want to ask on history. Because there's a lot of this direct-to-patient consumer marketing stuff out there these days that's a little crazy. But we know that some of the basic stuff that's been evidence-based for years still holds true. That tubal factor and male factor infertility are still the most leading, causes of infertility that need to be assessed and need treatment. And age is still the number one predictor of chance of achieving a live birth, and that hasn't changed either. That there's lots of other tests out there like AMH testing, other ovarian reserve testing that are being promised as tests of fertility that are really not tests of fertility. They're tests of response to hormones, And so I think, for the average family physician out there, I think it's really important to know that the basics are still true. Male factor is still important,
And it's true. So a couple things, because just some reading beforehand. Is it true that this affects 1 in 6 couples?
Yes, it's a very common condition. So it is something you're probably seeing in your office on a regular basis.
Right. And then the male factor issue, what percent is male, what percent is female?
It's still thought about a third is male factor and about a third is going to be sort of tubal and other female kind of factors. There's still a whole chunk of people that are unexplained, but unexplained can often just be age-related fertility decline as well.
So bringing back the notion to age, because in my practice, women are planning or thinking about conceiving later on in life. I don't have many early 20-year-olds who are family planning. So definition of infertility, can we start there? Does it matter on age? And is there a time period that we tell patients, try for this long? If it hasn't worked, then come and see me. Do you have any guidance with respect to that?
Yeah, the definition is still 12 months of regular unprotected intercourse. And I think that definition still holds. But to your point about where does age fit into that, it affects when you might refer somebody or start investigations. Because if someone's over 35, you don't have a lot of time to say, just try for a whole year. And then if it's not working, then we'll do the investigations. You want to pick up those things earlier because you have less time to work with to try and intervene on those problems. So it's still like subfertility when they've only been trying for 6 months, but you want to investigate them if they're over 35 at the 6-month mark.
And basic blood tests that you appreciate or work up for a patient who's coming to your office. So instead of just fertility, ? What do you like to see as just sort of a basic routine panel?
I would say a semen analysis is a very valuable test. I know they can be challenging depending on where you're working, where your practice is based to access a semen analysis, but there's usually one place somewhere that you can send a patient to do one. And that is probably the most valuable test to do early on. And if it's normal, it's normal. But if it's abnormal, it really needs to be repeated 3 months later because people can have bad days, with sperm production. Someone had a sleepless night. They drank too much alcohol the night before. People can have a bad day and a repeat test might be okay. So that's important. Tubal patency testing, if you have access to that, is valuable as well, particularly if someone has risk factors like a history of pelvic inflammatory disease, chlamydial infection in the past, pelvic surgeries, things like that. So that could be HSG, sonohistogram. It doesn't matter, whatever is accessible locally. In terms of blood work, it depends on whether they're ovulating regularly or not. The average woman has a regular 28-day menstrual cycle. They get those premenstrual symptoms. They know when they're ovulating. I tell them to go do the urine, ovulation predictor kits that they can go get over the counter from their local pharmacy. They're getting an LH surge. They're ovulating. You don't need to do any more extensive blood work after that. But the women who are not ovulating normally, and it's usually pretty obvious, their periods are changeable. They might be many months apart. They might be really short, close together. Anything that's really doesn't sound like a normal ovulatory cycle, that's when they need a full hormone panel. And that's where you want your FSH, LH, estradiol, and think about whether you want your thyroid, prolactin, and some androgens too to help you really differentiate what's the cause of that irregular menstruation.
Do you ever find the blood tests are very helpful? If they have PCOS, I guess, but do you ever find that the blood is really helpful?
Yeah, occasionally you get someone who you think, they're probably going to have PCOS. They're of the ethnic background I expected, and it's so common. And then I see an elevated FSH, and I'm thinking, okay, actually, this is someone who's hypergonadotropic. And, they're more in that peri-POI setting. We really got to move fast. We're getting close to. So yes, that can be helpful. And the hypos as well. Sometimes they're obvious. They're excessive exercisers. They're underweight. And sometimes it's not as obvious. They're the super, type A, hardworking, stress type who's maybe not sleeping so well. And it wasn't so obvious that they're actually quite hypothalamic. So that's where it can be helpful.
What about those ovulation kits? Any use?
Very useful. In fact, there's a good study that showed they're very effective and demonstrate they correlate very well with mid-luteal progesterone level. So if someone's ovulating on an LH urine stick at home, I do not feel they need to do a serum progesterone test. But if they're not, then I always recommend confirming with a mid-luteal progesterone test.
And are there any brands of ovulation kits that you recommend over others?
I just say go to your local pharmacy and buy a main brand. Some of the online ones that people order have been notorious for being kind of scams, not actually getting what you think you're going to get, but any big brand from a local pharmacy is fine.
And I'm asking this question because I generally don't know, and I'm hearing it all the time. And the quote is, my ovulation app told me this. What is an ovulation app?
There are tons of apps out there. Some of them are fantastic and some of them are just downright wrong. So you do have to be careful. There are some really good apps. Some are free, some charge money. Some use your ovulation sticks and you plug in the values and they tell you, whether you don't need that.
Okay, that would make sense. But if they're not using the ovulatory confirmatory test, what's the use of the app?
It's to help time intercourse. People are busy, and especially, your patients who are starting to try to conceive at 35 instead of 25, they're probably not having sex 3 times a week.
So they know that it's day 14 or day 12, 14. And is that still a thing? You tell them day 12, 14, 16?
Actually, I would say it's the 5 days leading up to ovulation. So if someone has a 28-day menstrual cycle, they're ovulating day 14. So it's the 5 days leading up to that. So 9 to 14 is you want to be having intercourse every other day in that time frame. And so most apps that work well, that have been validated, will adjust to their menstrual cycles. So if they have a 35-day cycle, everything shifts by 7 days later. And it'll start to learn, oh, you're a 35-day cycle. You need to be having intercourse later in this process. But some apps are just bad. So patients should look at what's, has it been validated? Because there are studies that have been done on some of these apps, who's selling what to them through this app. And if they're selling stuff, it's usually a problem. And some of them are have incomplete, completely wrong information. Like if you have sex these days, you'll have a boy, and these days you'll have a girl. That is just false information. So I always just ask, what app are you using? What is your menstrual cycle? And I'll look at it and go, yeah, this one fits. This one's right. It's telling you the right information. Or this one seems a little funny. There's some other good ones out there that are free. Why don't you try a different one?
So on the topic of preparation is a big issue in my practice. Your patients often a year, 6 months in advance of start date, where they're trying to conceive, come in and want some sort of boot camp. Boot camp, put me on a prenatal. What do you have to avoid? And if you Google it, you can imagine the plethora of things that patients come and ask their opinion of. But just distill it to common sense. A woman comes in with her partner. What are some tips? They're planning, they're very eager 6 months before they want to start trying. What are you telling them to do, not do?
So first of all, as a family physician, I would say focus on making sure they get healthy babies, so the general stuff. Don't drink alcohol, stop smoking, all the general stuff you would recommend for anyone who's pregnant. They should be doing that while they're trying to get pregnant. Take your folic acid, stay healthy, exercise. I see all these patients who stop exercising when they try to get pregnant, which is not good for them. Get your exercise, get your sleep. So the general good advice you would give to anyone who's pregnant, I would make sure their immunizations are up to date. They had their MMR, so they're immune to rubella because they can't get that vaccine when they're pregnant. Varicella too, right? So just some of the general family care preventative stuff. And then I would say, age is important. So why are you waiting? Why are you waiting 6 to 12 months? Why not start now? Do you know that it gets harder and harder? And then the chance of miscarriage goes up with time. Your chance of chromosomal abnormalities goes up. So just sort of telling them, get started. And when you have to have regular intercourse. So that's the other thing. You have to make time for it. And if it's going to be a challenge, then maybe get it up. Maybe get to know your menstrual cycle so when that fertile window is, so you don't lose those opportunities to try.
What about those things we hear from males about boxers, cannabis, and hot tubs?
Most of them are true. Generally, there's a reason the testicles are out in the scrotum and not inside the body. That's supposed to be in a cool temperature. So immersing yourself in very hot environments like saunas, hot tubs are not good for sperm. It reduces motility. cannabis, makes people lazy. It makes sperm lazy too. Not for everybody, but it's a risk factor, right? And so, yeah, those things are, I would say it's general good advice, like to stay away from those types of things. Yes.
I find it astounding because you go back to the basics and then patients are so disappointed that you haven't provided them with this, inner secret that's going to maximize their chances. But that's a good learning point, I think, for us and our listeners, that it's really just good primary care, support, and reality. I always tell patients I don't have a solution for aging yet. And if you really want to conceive, that unfortunately is something you just have to accept as part of the reality.
Looking at this, the big messages are age matters, check semen counts early. Check sperm counts early, confirm they're ovulating, make sure their tubes are patent, which is a bit hard for us to do. Anything I've missed? And the blood tests that are applicable.
Yeah, I was going to say in other places like Asia, Africa, they do like chlamydial antibody tests instead of tubal testing. It's very common there. Like in North America, because we have, I think, easier access to direct tubal patency testing, we don't do it. But interestingly, in a lot of like Asian and African countries, they just do chlamydial antibody testing. So I suppose if you could do that, but I know most people don't in Canada.
And that's the most common pathogen that's going to mess with the tubes, right?
Yeah, the most common by far. But, I think if you can't get access to tubal testing, that is very reasonable for you to ask your fertility specialist to do that testing, because every fertility specialist is going to have access to tubal patency testing.
Okay, that's great. Christine, any last questions or comments?
No, I encourage everybody to read the article that Claire she was a co-author, correct? In the British Medical Journal. So we have a Canadian thought leader here. We're very proud to have you with us, but it summarizes a lot of the information and it can be used as a reference. I think ultimately, it's just really down to basics, and time matters. And something very pertinent for my patients who are starting to conceive or trying to conceive later on in life.
Yeah, absolutely. And I think that is the message. Just give people, the support to just get started, like what's the reason for delaying? So just get going and try every chance you can, don't miss those opportunities.
Thank you, Claire, so much for joining us. Thanks a lot.